Discussing the tumorous conditions or discussing the neoplasms that can arise in the retina is very interesting. Now, just giving you or just recalling what is the retina, it's basically the neurosensory or the neuropigmentary layer. That is, again, it can be regarded as one of the protective layers that is covering the eyeball. So it's one of the layers of the three layers that we can talk about. It's the retina on the innermost side, it's the choroid, and then the outermost protective layer is the sclera. Tumors or neoplasms can arise in any one of these protective layers. When we discuss them or when we get to know the patients, we usually come across these different sorts of patients in which the tumors or the neoplasms arise in these different layers. Over here, we are just limiting our discussion to the tumors or the neoplasms that arise in the retina. Whenever we are dealing with a patient and we're suspecting that this patient is suffering from some sort of a neoplasm that is arising in the eyeball, that is affecting the visual acuity, of course, that has the mass effects, of course, and then it can also present as nystagmus or the squinting of the eyeball, that is also regarded as strabismus in a lot of patients. So usually you'll get a patient, a middle-aged patient, and it's not a gender-related problem that we're going to relate to. So usually you'll get these patients in your outpatient departments, and whenever you're suspecting that this particular patient is suffering from a neoplasm that is involving the retina, we're going to discuss what are the particular clinical features and how are you going to get a differential diagnosis of this particular leukocoria, or a congenital cataract can even be confused with this retinoblastoma at the initial presentation. So this is sometimes quite a confusing condition, and you should know how to make a difference between all of these clinical pictures at your hand. So just to start off by the tumors of the retina. Retinoblastoma, of course, is the most common occurring tumor of the retina. It's one of the primary tumors of the retina, and it's one of the tumors of the retina that is related to the pigmentary layer of the retina rather than the sensory layer. So astrocytomas, they're also included in this group of retinoblastomas, that is involving the sensory layer of the retina. So classification of the retina can obviously be, it can be classified into the primary tumors of the retina. Whenever we say the primary tumors of the retina, it means that the tumor has not traveled from some distant area of the body. It is primarily arising in the retinal structures, whether it is the pigmentary layer of the retina or whether it is the sensory layer of the retina, or it is involving the ganglions or the neuronal cells, whatever the case may be, it is primarily arising in the retina. So we have furthermore classified these primary tumors into Phacomatosis. It's the subgroup for the primary tumors. Phacomatosis can be defined as a neuroocular dermatological condition of the tumors. That means it has these three major components underlying this major heading, that is of the phacomatosis. Neuro means it's involving the central nervous system, and then it's involving the ophthalmic structures, and thirdly and lastly, it's gonna involve the skin of the individual as well. So usually it's a syndromic condition in which the patient has multiple neoplasms arising in the skin, arising in the central nervous system, and arising in the eyeball as well. So the clinical picture would be also correlating to all of these features. You would have to get a complete examination done for these patients, in which the examination of the skin, the examination of the nervous system, and then the ocular examination are the major components of the clinical examination in patients who are suffering from phacomatosis. Then finally, we have the mesodermal angiomatas. So it can be even the vessels that are sometimes involved, and whenever there are these angiomatas that are involving the vascular walls, we're going to regard them as the mesodermal angiomatas over here. Then finally, we can have the neuroblastic tumors. Neuroblastic tumors can be further classified into the pigmentary layers, the tumors that are involving the pigmentary layer. And then we can have the tumors that are involving the sensory layer of the retina. Tumors involving the sensory layer of the retina, the examples would consist primarily of retinoblastoma, and then we have astrocytomas on the other hand. And then we have the tumors that are related to the pigmentary layer of the retina. That basically consists of the malignant melanomas. It is one of the notorious pigmentary layer neoplasm over here. And then we have the benign epithelium tumors as well that can arise in this condition. So usually you have a combination of benign and malignant tumors in these patients as well. Then we can have the secondary tumors on the other hand. Tumors can metastasize from the different areas of the body. It can be the metastatic malignant melanomas on one hand. Melanomas are usually traveling from the skin towards the eye. So it can be one of the metastatic conditions. Then you can have the metastatic sarcomas in these patients. We can have the metastatic carcinomas that are, again, malignant in their nature. And then finally, we can have the direct extensions from the nose, from the cranial cavities as well, or all of the related structures. Even it can be the skin conditions or the skin neoplasms that can get correlated to the ocular extensions. We can have the middle ear neoplasms that can travel or that can manifest as the ocular neoplasms later on. So sometimes it's quite a mixed picture. For these patients who have secondary tumors, you have to just notify the fact whether it is a metastatic tumor or whether it is the primary tumor of the retina itself. So distinguishing or differentiating this clinical picture is very important. When you have that patient at your hand and you know how to examine the different systems of the body, and obviously, you're going to perform the lab investigations that involves the CT scans and the higher investigations such as MRIs, even the DEXA scans involving the bones. So all of these are done in these patients, normal procedures, all of the procedures that are followed for the different cancer patients, they are done for these patients as well. So this is the classification of the retinal tumors primarily. The most important or the most notorious ocular neoplasm is the retinoblastoma. It's, again, I would like to emphasize that it's one of the primary tumors of the eye, which is involving the sensory layer of the retina. So this is the definition of the retinoblastoma, and usually it appears as a tumor. It can appear posterior to the equatorial line, or even it can appear just related to the ora serrata and related to the macula, or even it can arise in the fovea centralis. So it depends upon the size of the tumor. Again, it's very important just to focus on the size. The clinical presentation is going to be affected by the size of the tumor as well as the location of this retinoblastoma. Obviously, if it is involving the macular structures or if it is involving the foveal structures, then again the clinical picture would be quite different, in which the central vision of this patient would be affected. Obviously, if it is a mass effect and the tumor has grown out, it is going to present as a leukocoria, that is a white reflex, a white pupillary reflex, and that would give its differential diagnosis furthermore. And then you would basically list up the differential diagnosis and differentiate this condition of retinoblastoma from the other conditions that can also give rise to the white pupillary reflex, which is also known as leukocoria. They're also known as the pseudogliomas. So it's another terminology that is used for these retinoblastomas over here. Then just having the demographic data of whenever we are considering the retinoblastomas, we just have to got a view that it's basically the most common intraocular tumor that we're talking about. So it's most notorious, it's most malignant. The prognosis is not quite good for these patients, and it's also the most commonly occurring intraocular tumor. Then it's basically confined to infancy. So it's usually diagnosed in the first year of life. So it's usually confined to the infancy. It's sometimes regarded as a primary congenital tumor of the retina. Then no sex predisposition, so it's basically the males and the females are equally affected by this condition, and there is no gender discrimination over here. The things that you can correlate to whenever you're taking the history from the patients: the age of the patient, the gender, the locality that the patient belongs to is very important that you're going to consider. Then 25 to 30% cases, there is a bilateral involvement, although it can be a unilateral condition just affecting one of the eyes, either the left or the right side. But in almost 30% of cases, it's a bilateral condition that we're relating to over here. Then dealing with the genetics, so just you have to keep in mind that there got to be an oncosuppressor or a tumor suppressor gene that is being deleted, or it's being mutated in these patients who are suffering from retinoblastoma. That is basically giving rise to this tumorous or this neoplastic condition. The gene involved is the RB1 gene that we're talking about over here. So the germline of the RB1 gene, first hit is passed on in the germ cell. So it can give rise to the secondary cancers, and even the second hit in the retinal cells would give rise to the bilateral multifocal retinoblastomas in these patients. So this is basically the hitting phenomena that we're talking about. It can be a first hit. A first hit would basically relate to a slight mutation at the genetic level. And the second hit would further deteriorate the condition for the patient. So this would be a germline retinoblastoma condition, and then we have a non-germline retinoblastic condition. The first and the second hits in the retinal cells, they occur for the patient, and then it gives rise to the unilateral retinoblastoma in these patients. Furthermore, we have the deletion syndrome. Remember, we talked about the conditions of Phacomatosis. Again, they were the syndromic conditions that we were talking about. For example, we have the von Hippel-Lindau disease, we have the Bourne-Willis disease, the Sturge-Weber's syndrome. All of these are basically the syndromic conditions that we are referring to. They are going to arise due to the RB1 gene deletion syndrome. So it's just not going to be the slight mutation or the deterioration that is affecting at the genetic level. Rather than it's going to be a deletion phenomena that is occurring for the patients who are suffering from a syndrome that is involving the ocular structures, that is involving the patient is having skin manifestations, as well as the central nervous system is also involved. And obviously it's quite a debilitating condition that is going to arise for the patient, because the patient is finally going to suffer from ocular conditions, mental retardations. So all of these scenarios are going to occur for the patient. The genomic deletion is going to occur, and that is going to give rise to the neurodevelopmental delays of the patient. The milestones over here would be very important to consider when you have that infant and you're thinking that on the lines that this patient is suffering from retinoblastoma, you're going to note down the milestones for the patient. And if the milestones are delayed due to the phenomena of the neurodevelopmental delay in the infant, then only we're going to consider the genomic deletion for the infant. Even these patients have these dysmorphic features that are quite characteristic in the cases of retinoblastomas. But you'll have to remember that this is not an isolated case of retinoblastoma. That would be a syndromic baby, a syndromic infant that we would have at our hand. He'd be suffering from central nervous system manifestations as well as skin conditions or the skin neoplasms as well. Then finally, the occurrence or the prevalence of this condition, just discussing or just having a look at the statistics over here. Of all the cases that we talk about, 10% are familial, and then we have 90% sporadically occurring cases as well in these patients. So then we have the sporadic cases, and when we can further classify them into 60% who are suffering from the somatic mutations, and then we have the 40% who are suffering from the germline mutations. So the germline mutations would be usually a primary retinoblastic condition. Usually it is a unilateral condition that is arising in these patients. And these 60% patients who have somatic mutations as well, they would have a multiple syndromic condition that the patient would be suffering from, involving the central nervous system, involving the skin, and even involving the other systems of the body as well. It is basically a heritable or the germline cases that the first hit genetic mutation is very important over here, in which basically both of the genes are affected, in which both of the eyes are affected, and that is basically important, in which we have the retinoblastoma positive gene in both of the eyes. And then we have a second hit mutation that is allowing it to be of the, this mutation can be called as the somatic mutation, in which we have the retinoblastoma negative gene all over in all of the 46 chromosomes that we're talking about. So it would be the second hit that is most debilitating for the patient. Whenever we are talking about the changes that are occurring at the germline or at the genetic level, the changes that are occurring in both of the genes of the eyes. So the non-heritable or the somatic cases, when we talk about them, the first and the second hit and the somatic mutations, they can occur in these patients, in which it's basically not a heritable condition. Both of the parents are comparatively normal in this condition. There is a positive the retinoblastoma positive gene is present in both of the parental coincidences over here. And then after the somatic mutations, we have one of the parent that is basically suffering from a gene deletion phenomena that you have to keep in mind. And this gene deletion is going to give rise to the syndromic conditions that we have already mentioned. So these were the protective layers that we were talking about. There is this sclera, then we have the choroid, and then the innermost layer, which is basically regarded or termed as the retina. A benign lesion can arise over here due to the biallelic RB1 mutation or the MYCN amplification over here. So either it can be a mutation that was regarded as the first hit or the somatic mutations that can occur over here, and that is basically going to give rise to the benign lesions that can occur at the retina. And furthermore, the malignant conditions can arise due to the additional alterations that are driving the tumor progression. So that is basically going to debilitate the picture much more, and a much malignant condition is going to arise. The tumor is going to progress clinically as well, stage-wise as well. The surrounding structures can be involved along with that, and that is basically going to give rise to a malignant condition of the retinoblastoma. And then finally, obviously, it can involve the vitreous compartment on the whole. It can be a massive structure, and obviously that would be regarded as the advanced retinoblastoma stage over here. The further clonal evolution via the genetic alterations would further deteriorate the condition for the patient. So, if it is a primary tumor that is primarily involving the retina, then it can further deteriorate the condition. Even the benign tumors, after the second hit or after the somatic mutations, they are going to be deteriorated and they are going to be relatable to a malignant or a progressive tumor that we can have after these genetic alterations. Whenever we say or whenever we use the word alterations, it means it's not just the mutations, it can be the deletions that can occur at the genetic level, and obviously the clinical picture of a patient in which a genetic deletion has occurred. That would basically encompass or coordinate with a syndromic picture for that baby. So even all of these advancements can occur after the benign lesion occurs, and there are the further enhancements for the clinical syndromes in these patients. Having known the underlying pathology of having a retinoblastoma or the development of a retinoblastoma in the patients, there are these particular features that we're going to look for if we have excised the retinoblastoma or we have the biopsies we are looking at under a microscope. So what are these particular features that we would be looking for if we are suspecting it to be a case of retinoblastoma? These particular terminologies or these particular features are shown over here. First of all, we have the Flexner-Wintersteiner rosettes. So it's a rosette-like appearance, as you can just appreciate over here. Under the microscope, you would look for these rosette-like structures that are quite visible in this retinoblastoma, and these are termed as the Flexner-Wintersteiner's rosettes over here. And then finally, we have the Homerite rosettes. So if there is this mucocutaneous filling over here, it can be a discharge that is being collected at the center of this rosette-like structure, then we're going to regard them as the Homerite rosettes over here. So these are these particular terminologies that are given and that we're going to look for whenever we are looking at the slide of a retinoblastoma patient. The undifferentiated tumor cells, they are quite numerous in number, and these are the particular histological features that we're going to look for and how we're going to make a definitive diagnosis of retinoblastoma. So obviously the treatment is going to be encompassing after you have that definitive diagnosis of retinoblastoma, whether you're going to go for the chemotherapy or you're going to encompass your radiotherapy, or whether it is just a benign tumor that has occurred and you have excised that tumor and that's enough. So this is very important, that how you make the definitive diagnosis in these patients. On the basis of all of these histological features, you can diagnose the patient to be suffering from retinoblastoma, and then you can manage accordingly or make out a treatment plan accordingly for these patients of retinoblastoma. So how are these patients going to present in the clinics? The clinical features that you're going to look for is very important. The symptoms that the patient would be usually complaining of are the decrease in the visual acuity, and then there can be the symptoms of secondary glaucoma in these patients due to the pressure effects that are arising in these patients. So leukocoria, that is almost 60% of the patients are suffering from this white papillary reflex phenomena. It's very important that you know how to basically demonstrate this white papillary reflex. You're going to just throw some light on the pupils of the patient, and that would give off a white reflex that is an abnormal white reflex. In normal patients, you usually get the red reflex, which is the normal that has to occur for the child or for the patient that you're examining. But if it is a white reflex that occurs when you throw light on the pupils, it's basically termed as leukocoria, And there are these range of differentials for the leukocoria. It's just not the retinoblastoma. If you have a patient of white pupillary reflex, you're just not going to keep in mind that it's just a patient of retinoblastoma and that's it. No, you have a list of diseases that can present as leukocoria in your clinics. So you'll basically perform the lab investigations for this patient, and then you're going to have the definitive diagnosis at your hands. And finally, the patients can also suffer from strabismus. In 20% of the patients, the clinical presentation is relating to strabismus, that is also known as the squinting phenomena, in which when the patient is asked to look at a fixed point, at a fixed distant point, both the eyes are not coordinated. So there is no coordinated eye movement in these patients, and only 20% of the patients who are suffering from nystagmus have retinoblastoma as the underlying cause for the development of this strabismus in these patients. So it can be one of the clinical presentations as well. Along with strabismus, we have nystagmus. That is again the rapid eye movements that are sometimes seen in these patients. And then we can have the painful red eye in almost 7% of the patients. Painful red eye, there is again a list of diseases that is going to manifest as a painful red eye, ranging from even the benign conditions such as inflammatory or infectious conditions that would even present as this painful red eye. So in almost 7% of the patients, that's just a very small percentage. The underlying cause, when you investigate the patients furthermore, the underlying cause is thought to be the retinoblastoma in these patients. So it can be one of the clinical presentations as well. And then decreased visual acuity. So a poor vision or a decreased visual acuity can be one of the ophthalmic features or one of the clinical features that the patient may be suffering from. Usually there is just not a single symptom that the patient would come up to you in the clinics. It's usually a range of these symptoms. It can be a slightly red eye. Along with that, the patient may be suffering from nystagmus or strabismus, and then even this presence of leukocoria. That is a very important sign for the diagnosis of retinoblastoma, and just a catch that you have to find out whenever you are clinically examining an infant in most of the cases. So you will have the differential diagnosis of retinoblastoma at your hand in these patients. Then furthermore, we can have the patients who are asymptomatic. In almost 3% of the patients, we have no symptoms at all. And then the unilateral mydriasis. Miosis is basically the constriction of the pupils, and mydriasis regards to the dilatation of the pupils. So the dilation of the pupils is sometimes regarded in almost 2% of the cases. It is regarded as to be due to the cases of retinoblastoma. And then we can have the orbital cellulitis. Finally, we can have the heterochromia, iridis, and hyphema in these patients in almost 1% of the cases. The heterochromia is basically in which the iris is basically different in both of the eyes. So it's not bilaterally equal. So if you have patients who have the eyes of different colors bilaterally, that would basically regard as to be that the patient may be suffering from retinoblastoma. And then hyphema is one of the clinical presentations. So it's not always the case, as you can just relate to the fact that it's almost 1% of the cases in which heterochromia is relatable to retinoblastoma. So these are just the slight percentages, but still there are cases who have been reported like this. Patients with orbital cellulitis were finally diagnosed with retinoblastoma, or patients with heterochromia were finally diagnosed upon further investigations as they are suffering from retinoblastoma. So just have to keep in mind and just have to be quite cautious when you are examining these patients and you have these patients at your hand. You have to keep in mind the retinoblastoma, the diagnosis of retinoblastoma in your mind as well, and you have to investigate the patients accordingly. The intraocular stages of retinoblastoma, first of all, we have the quiescent presentations that are sometimes seen for these patients. Quiescent presentations are the typical presentation, the typical clinical picture that is usually seen in these patients. Then we can have the exophytic retinoblastomas, and then finally we can have the painful red eye presentations. The quiescent presentations were all of the presentations that we had already talked about, ranging from leukocoria, nystagmus, strabismus, or the orbital cellitis, heterochromias. These are included to be the quiescent presentations. The exophytic retinoblastoma has this particular cottage cheese appearance that is quite particular to this exophytic retinoblastoma. When you have that ophthalmoscope at your hand and you're looking at the fundus of the patient, that would give you a particular or a typical cottage cheese appearance that is very suggestive of the exophytic retinoblastoma. And then sometimes a painful red eye is relatable to the retinoblastoma, or these are sometimes relatable. So these are the clinical presentations that you can come across, and you are sometimes not looking for that typical picture. Sometimes there is an atypical patient, and on further diagnosis, you would get to know that this patient is suffering from retinoblastoma. So the intraocular stages of retinoblastoma can be, obviously, we're going to first of all look at leukocoria, if the patient is suffering from leukocoria. And then the patient can also have defective vision. So it would not directly start off with a defective vision in that individual. The first presentation or the initial picture would be just of a leukocoria. That would again give rise to the defective vision in that individual. And then finally, the nystagmus, that is the rapid oscillatory movements of the pupils. They are known as nystagmus. So it's basically a to and fro movement of the pupils that is regarded as nystagmus. Obviously, it occurs due to other multiple causes as well. One of them is retinoblastoma. And then squinting or strabismus is another stage of the retinoblastoma. Talking about or considering the endophytic retinoblastoma, one should keep in mind that there is this cottage cheese appearance that we usually talk about. There is this growth, there is this endophytic growth that is occupying the vitreous cavity as well. On further investigations or on performing the ophthalmoscopy or funduscopy, that would reveal these particular mass that is growing endophytically. And then you can furthermore perform the CT scans and MRIs just to assess the growth of the tumor that we talk about. Then finally, we have the exophytic retinoblastoma that would be underlying, and then this is the particular appearance of the exophytic retinoblastoma. And upon the further evaluation and upon performing the FFAs, that is the fundus fluorescence angiographies, or performing the CTs and MRIs involving the orbital cavity, would further have the definitive diagnosis in these patients. Painful red eye presentations, they are sometimes very common, and sometimes there is a coloboma or there is a ring defect that is occurring in the iris, and that is sometimes relatable to these tumorous conditions as well. So the acute secondary glaucoma is one of the conditions, and the apparent intraocular inflammations, they occur in these patients. And furthermore, it can be even a case of orbital cellitis involving the extraocular structures, involving the skin, that is skin of the eyelids, or the tissues that are surrounding the orbit. They are sometimes inflamed. So these can be the three particular conditions. It can be an intraocular inflammation, it can be an extraocular inflammation, or either it can be a secondary glaucomatous condition that is giving way to this retinoblastoma. We have this Rees-Ellsworth classification. It's again one of the ways in which we can stage retinoblastoma from mild, moderate to severe condition. So it's one of the staging mechanisms that is employed. In group 1, we have solitary tumors in which we have less than 4 disc diameters, and there are sometimes the multiple tumors in which none over 4 disc diameters is involved. It's the optic disc and the distance from the disc that is very prevalent, or that is very significant over here. Furthermore, if the disc is not involved, it means it's a benign condition, or if it is not going to affect the vision as much. But if it is affecting the disc, or if it is affecting the macula or the fovea, the visual acuity is going to be affected utmost. In group 2, we have the solitary tumors that is almost less than 4 to 10 disc diameters, and if it is a multiple tumor, none over 4 to 10 disc diameters. In group 3, we have any lesion anterior to the equator, and these solitary tumors are sometimes more than 10 disc diameters behind the equator. So equator was the midpoint, this basically the equator of the retina that we're talking about. So if it's a solitary tumor in group 3, it's going to be almost more than 10 disc diameters behind the equator. It's furthermost away from the optical disc that we talk about. So these are the first 3 groups. And then we have the group 4. That is basically having the multiple tumors, some more than 10 disc diameters. And we have the solitary lesions extending anterior on to the ora serrata. So it's basically involving just the margins, just the ora serrata of the retina that was just marginal, quite away from the optic disc, so it's not going to be affecting the visual acuity as much. So as we are furthermore moving down the groups, the disease is basically not quite significantly affecting the visual acuity in these patients. We have the group 5 disease disorders in which we have a massive tumor over half of the retina. And then we have the vitreous seedings as well in the group 5. So if it's just the vitreous seedings, we're going to be relating it to the group 5 disorders. So these are the this is the classification which is known as the Rees-Ellsworth classification, and it's for the retinoblastomas. Then we have the ICRB classification in which we have a low risk group, and we have a group A which is very low risk. We have a group B which is low risk, and then we have a group C which is almost moderately risky, and a group D which is at a higher risk, and then finally we have a group E which is at a very high risk. So it's basically an ascending manner that is followed down in the ICRB classification, in which the risk factors are quite increasing as we go down the groups. The other stages are the stage of the extraocular extension. So once the retinoblastoma is left untreated, it has a very aggressive behavior. It is going to involve the extraocular structures as well. It can involve the skin, and it can even involve the distant organs, that is the brain, the kidney, the liver. They can be involved. So it's very important that you know that we can have the later stages in which there is an extraocular extension, a direct extension to the nasal cavity, to the cranial cavities, or it can be a stage in which there is distant metastasis following after that. The differential diagnosis would consist of leukocoria. We can have the exophytic retinoblastomas, and then finally we can have the endophytic retinoblastomas. The differential diagnosis of leukocoria, it can be of a congenital cataract. It can even be the cyclitis that we can talk about, the choroiditis. We can have the retinopathy of prematurity, or the patient can also suffer from toxoplasmosis cara. So these are the differential diagnosis for leukocoria. It's just not the retinoblastoma that you have to keep in mind. You have to further investigate the patient and get to know what is the cause of this white pupillary reflex defect that has occurred in the infant. So the further investigation is going to reveal the situation. Then we have the differential diagnosis for the exophytic retinoblastomas and even for the endophytic retinoblastomas. So you have to consider whenever you have these situations at your hand in the clinics, you should know how to get to the definitive diagnosis in these patients. The diagnosis would also be made on the fundus examination that can reveal the cottage appearance. The ultrasonography is very important. And then finally, we can perform the MRIs for these patients as well. The CT scans are performed. We perform the plain X-rays of the orbits, and then finally the LDH levels are raised in the aqueous humors. So all of these investigations, and that is going to relate to the final definitive diagnosis in these patients. The treatment would be relatable to chemotherapy. If it can be treated just by the chemotherapy, we have to stick to that. And finally, the chemotherapy is done by having this cinblastin, vincristine, and abiplastin regimen. So it's basically the standard dosages of the CVE regimen that is guided on to these patients. Then if it is not responding to this treatment, we can perform the high doses of this CVE regimen as well. The focal therapy is also done for these patients, and that would relate to the cryotherapy. Then even the thermotherapy is performed. And then finally, we can have the laser photocoagulation done for these patients. And even in a lot of patients, we consider the block radiotherapy that is performed, and we can also relate to the external beam radiotherapy. So if it's just a small focus or if it's a benign tumor, we can relate to all of these cryotherapies or the laser beams, thermotherapies, and block therapies. So this would be the management plan for the patients in which we are considering a focal treatment for the patients. We can further perform enucleation. That would be just the excision or the complete removal of the tumor, or the whether it is a benign or whether it is a malignant condition. The palliative treatment would consist of the retinoblastoma with orbital extension. We can also consider this for retinoblastoma with intracranial extensions or retinoblastomas with distant metastasis, in which we cannot perform all of these focal therapies. We're going to perform the palliative therapy just to improve the quality of life for these patients. The prognosis for these patients, if it's left untreated, it's quite a bad prognosis. Rarely spontaneous regression occurs after treatment. And nucleation, if it is performed in patients, the prognosis is quite fair for these patients. We can also have the optic nerve involvement, and if there is an optic nerve involvement, the prognosis would not be so good for these patients. If it is a massive choroidal invasion, even in these patients, they would suffer from a deliberate hemorrhagic phenomena in the vitreous, and that would be, again, having a bad prognosis. Enucleation is a procedure in which the conjunctiva and the Tennant's capsule are separated first of all, and that is followed off with the separation of the extraocular muscles. Then there is the cutting of the optic nerve and removal of the eyeball. And finally, after you insert the orbital implant, you perform the closure of the conjunctiva and the Tennant's capsule. We can also apply for an artificial prosthetic eye in these patients. Without an artificial eye, it's not quite a cosmetically acceptable view for these patients. So if you have this artificial eye prosthesis available, you'll perform this implants, or you will have these artificial prosthetic eyes that were implanted for these patients. Phacomatosis, as we've already gone through, it's basically the syndromic conditions. Usually these are the neuro-oculo dermatological manifestations that occur in these patients. So there are these three major components that we usually have in these patients. For example, the examples would include angiomatosis retina, which is also known as the von Hippel-Lindau disease. It's one of the syndromic conditions that occur. We have tuberous sclerosis, which is also known as the Bourne-Wills disease. And then we have the neurofibromatosis. Finally, we have the encephalophageal angiomatosis. The other normal or the layman terminology that is used for this condition is the Sturge-Weber syndrome, in which usually the patients present with a big strawberry nevi on their face. So these are the conditions in which even we have the ocular manifestations, we have the central nervous system manifestations, and on the other hand, we have the dermatological manifestations in these patients. So to treat these patients, you're going to have these three major categories of these symptoms, and you're going to treat them accordingly and according to the severity of the disease that the patient is suffering from. So in this lecture, basically, we summarized the condition of retinoblastoma and also the other accessory conditions in which we can even have the syndromic conditions in which we have the ocular tumors, particularly relating to the retina. We have the skin manifestations, and even sometimes it can be a debilitating condition involving the central nervous system, and mental retardation can ensue in these patients. So you should know how to manage these patients accordingly, and what are the treatment guidelines that are inculcated for such patients. So that is the end of this lecture. Thank you for watching sqadia.com.